Let's solve some hematological cases. First case is a case of a middle-aged man with pathological fracture of the femur, upper end of the femur. Pathological fracture is some fracture which is it happens when there is no obvious injury or a trivial injury. He's been also complaining of fatigue, bone pain. He has pallor, cardiac respiratory systems are normal. He's got a high ESR. The blood picture is normocytic, normochromic. The peripheral smear shows marked roller formation. The Buffy coat, which is obtained and smeared, shows loss of plasma cells. Bone marrow examination also reveals mature and immature plasma cells. Total plasma protein is elevated 10 grams, more than 10 grams per deciliter. Albumin globulin ratio is reversed. Normally it is 2 is to 1. It is reversed 1 is to 2. The abnormal protein called Bence-Jones protein is also detected in the urine. Protein electrophoresis reveals a gamma fraction which is increased, spike in the gamma region. So a diagnosis of multiple myeloma, a tumor or a neoplasm which affects the plasma cells, is arrived at. It's multiple myeloma is a cancerous growth of plasma cells. Now let's look at the question. The question is, which of the following is the cause of the reversal of the albumin globulin ratio? So now we have to look at the cause of the change Ag ratio. I said normally it is 2 is to 1. Albumin is twice as globulin, but 4.8 albumin, 2.3 globulin milligram per deciliter. So globulin is 50% of the albumin. Here it is reversed, means either albumin is low or globulin is high. Because of the history and investigation, it is obvious that the globulin fraction is more. Let us see the options. A. Decreased synthesis of albumin by liver. You can exclude this because there is no evidence of liver failure. So albumin is out of question. Decreased albumin is out of question. Decreased formation of the gamma fraction of plasma protein by liver. Liver does not produce gamma fraction, so in fact here it is increased. So this is out of question. B is also out of question. C. Increased production of gamma globulin by plasma cell proliferation. It is obvious in the case. So abnormal proliferation of plasma cells have increased the gamma globulin. We know that plasma cells produced gamma globulin. Plasma cells are changed lymphocytes, B lymphocytes, during immunological processing. And there is a foreign antigen which produced the lymphocyte development. Antigen triggered lymphocyte development, B lymphocyte development, produces clonoplasma cells which produce gamma globulin. They are the antibodies or immunoglobulins, different immunoglobulins. So here the abnormal immunoglobulin is present, which is called as the Bence-Jones protein. It's a gamma fraction protein. So that is a diagnostic criteria for multiple myeloma. It causes anemia, fracture, etc. as seen in the case. So the fourth B option is hypergammaglobulinemia. Of course, there is hypergammaglobulinemia due to an underlying infection. There is no evidence of infection here, so it can be ruled out. So answer is C. Let's go to the second case. Yes, a boy brought for generalized swelling of feet, abdominal distension, face puffiness, recent development. A similar history was there some time back, it subsided. So there is recurrent swelling. On examination, there is anasarca, the generalized swelling, slight fever, massive proteinuria, 4 plus proteinuria. So protein is getting leaked in the urine. Urine does not contain protein normally. 24-hour urine output is normal. Albumin is low. 4.8 becomes 2.8 grams per deciliter. Diagnosis is given. Diagnosis of nephrotic syndrome is made. And what is nephrotic syndrome? It is a disease which damages the selective permeability properties of glomerular filtration barrier. Glomerular filtration barrier is highly permeable, but at the same time, it is selectively permeable to solutes, highly permeable to water, plasma water. So large amount of filtration is there, but selective permeability to solutes. So proteins are not let into the glomerular glomeruli. That is the Bowman's capsule. The protein is normally absent in the filtrate. Here the protein is present because of the damage to the filter, glomerular filtration barrier. There's the problem, pathogenesis in the nephrotic syndrome. It is a autoimmune disease. This causes edema. One of the pathogenesis of edema is the loss of albumin, hypoalbuminemia, decreased colloidal osmotic pressure. Let's look at the question. What is the question? Is yeah, it is boys edema is only asked. Why? Hypoalbuminemia by urinary loss. That is obvious. Yes. Hypoalbuminemia. Albumin in the plasma is less due to urinary loss. Let's look at the other options. But elevated capillary hydrostatic pressure. There is no venous obstruction, no failure. Increased blood volume is not a cause of edema as such. Decreased crystalloid osmotic pressure. It's also ruled out because crystalloid osmotic pressure changes do not cause edema. Because across the capillary, in the pathogenesis of edema, it's the colloidal osmotic pressure which is important because plasma proteins are confined to the intravascular compartment. So crystalloid osmotic pressures is not a factor in the pathogenesis of edema or in the capillary fluid shift. So answer is A, hypoalbuminemia. Case 3. A middle-aged woman also presents with swelling of the left lower limb, non-pitting. So when you say non-pitting, it is lymphatic edema. It is a mild pallor and diagnosis of filariasis. The limb swelling, elephantiasis, as if the limb looks like elephant's leg. Only a single leg is swollen. This is due to the fact that the lymphatic vessels are damaged by the filarial worms. So it's a filariasis. It's the infestation of the filaria worms called Wuchereria bancrofti. So there's damage in the lymphatic vessels. Damage in the lymphatic vessels is a very important cause of edema. So called lymphedema, which is non-pitting. Of course, she is treated. Let's look at the question. Destruction of the lymphatic vessel causes edema because loss of albumin across the cutaneous capillary. Lymphatic obstruction is the damage to the lymphatic vessels which start at the interstitium, which drain the excess fluid in the interstitium during capillary fluid exchange. So here there's no loss of albumin across the cutaneous capillary because the pathogenesis of lymphedema does not affect the cutaneous capillaries. if there is no increase in the capillary permeability. So this is ruled out. Increased interstitial hydrostatic pressure is a probable cause because the lymphatic obstruction results in high interstitial hydrostatic pressure because of accumulation of the interstitial fluid, which is not drained by lymphatics. So gradually in days together, interstitium swells with the fluid. Initially, this increased interstitial pressure increases in driving forces and prevents edema. Safety factor is already in place, but when the safety factor is overcome, high degree of interstitial pressure will ultimately result in edema. So B is the probable answer. Let's look at C. It decreased colloidal osmotic pressure in the interstitium. Colloidal osmotic pressure in the interstitium is very negligible. Even in the case of lymphatic obstruction, there is hardly any protein. Maybe slightly increased protein may be there because it is not being drained by lymphatics to the blood. If at all, there should be increased colloidal osmotic. So ruled out. Elevated venous pressure. There is no indication of venous pressure being elevated. No venous obstruction. It's lymphatic obstruction. No cardiac failure. So the answer is B. Increased interstitial hydrostatic pressure. Next case. A 40-year-old one had radical mastectomy. That is a removal of the breast tissue. Radical means the lymphatic tissue around also is draining lymphatics. Lymph nodes are removed. Radical. Because of the cancer breast. Carcinoma breast. So axillary lymph nodes we drain from the mammary gland are removed so that the carcinoma tissues, everything is cleared. This is the treatment of choice for the carcinoma breast. It's highly effective. But later she presents with the left arm swelling. It is attributed to the lymphatic vessels. This is quite common. Lymphatic vessel obstruction, as we saw in the previous case, as a result in no edema. Now let's look at the question. What is the question? Now, which is a cause of edema in this? We already answered this, but let's see the options. Decreased oncotic pressure in the capillary. No, there's nothing to do with the oncotic pressure here. Oncotic pressure is due to the plasma protein. They are not decreased. So, is not the answer. Increased hydrostatic pressure at the venous end. No, because there's no venous obstruction, no cardiac failure. B is also ruled out. Decreased in driving filtration pressure at the capillary. In driving filtration pressure at the capillary. Let's keep this just pending. Let's look at the D. Increased interstitial hydrostatic pressure. This is the answer. The best answer is increased interstitial hydrostatic pressure. Let's look into the C. Is it decrease in driving filtration pressure at the capillary? In driving pressure for filtration of the capillary is the colloidal osmotic pressure, which is constant along the cutaneous capillary. Hydrostatic pressure has decreased. So there is a in driving force. So normally there is no fluid left in the interstitium because of the almost equal in driving force and out driving force. So decrease in driving filtration pressure will occur only when the colloidal osmotic pressure is reduced. In fact, here there will be slight increase in the in-driving filtration pressure, as I already told you, because of accumulation of fluid in the interstitium and increase interstitial hydrostatic pressure. The D will increase the in-driving force, not decreased. So C is ruled out. So it is the increased interstitial hydrostatic pressure. D is the answer. Now let's look at the cause of edema. In both the previous two questions can be answered by a diagram. Lymphatic vessels originate as blind-ended capillaries at the interstitium. The arterial end of the capillary and the venous end, arteriole venules are shown here. Lymphatic vessel here is destroyed and the lymphatic flow is blocked. gradually results in increased interstitial pressure. Let's look at the other arterial end, venous end. This is outdriving force at the arterial end. Hydrostatic pressure in the capillary 36. Pi c, capillary oncotic pressure 25. So there is about 11 millimeter of fluid pressure, millimeter mercury for outdriving pressure. The fluid moves at the arteriolar end is called filtration, and the venous end the hydrostatic pressure falls because of the capillary dynamics called circulatory dynamics. So it falls to around 16, 36 to 16, but the pi c remains the same. So the venous end of the capillary there is 25 minus 16, 9 millimeter. Here about 11 millimeters of outdrawing force. So reabsorptive force about 9 millimeter mercury. 11 here, 9 here. So because of this, there is a slight imbalance in the outdriving and the indriving force, 11 and 9. But this is drained by the lymphatics normally, like this. It goes back to the venous system. If you know the anatomy of the lymphatic vessels. Now, when a lymphatic obstruction occurs or destruction occurs, there is accumulation of interstitium. There's a slight development of interstitial pressure. So this adds to the indriving force. Let us say this is adding about 3 or 4 millimeter or 5 millimeter. This indriving force will be much more. If I 69 plus about 14, so 11 and 14, there will be more and more as the fluid accumulates. It is being reabsorbed. So reabsorptive pressure is more in this case. So that will prevent edema for a long time. Safety factor is called that. But a lot of fluid is accumulated. This is not enough to cause the fluid to go back. This swells up. This area swells up. So it's called lymphatic edema. Just non-pitting because of the fibrosis, the lymph by the lymph composition of the lymph, the fibrosis. It doesn't shift. Fluid does not shift. Non-shifting or non-pitting edema. This is a pathophysiology of edema and lymphatic obstruction. The next case, the firstborn infant of Rh negative lady has evidence of hemolysis. She had 2 second trimester abortions. So probably she didn't know her group or ignored. Infant is now the infant, born infant said to be suffering from erythroblastosis because of hemolytic disease. This could have been prevented by administering anti-D antibodies to the mother on the termination of each of the first pregnancies. During the abortion, if she had been given anti-D antibodies, this could have been prevented. She would have had a normal delivery of the normal child. That didn't happen. Let's look at the question. What is the role of these anti-D antibodies? The anti-D antibodies have which are the following roles in preventing erythroblastosis fetalis in the further pregnancies? They cause agglutination of the Rh positive red cells, cause agglutination of the Rh negative red cells, prevent antigen antibody reactions. They hemolyze the Rh negative cells. Let's, if this is confusing, answer. Everything looks little same. If you do not know the pathogenesis of erythroblastosis, what is the answer? Agglutination, positive cells, negative cells, antigen antibody reaction preventing also will prevent the pathology. Hemolyze of negative cells. We don't know what is the role of negative cells if we are not sure. Let's look at the pathogenesis. Erythroblastosis fetalis is caused like this. Mother is Rh negative, fetus is positive because father may be positive. So fetus is positive. So it has antigens on the RBC surface, D antigens. This spikes represent D antigen. The spiked RBCs are positive cells. These are naked ones negative. Placental barrier normally prevents this exchange of these formed elements. So mother and fetus normally does not occur, but sometimes at the parturition some leak may be there. Some few RBCs may enter first pregnancy during the delivery. So first pregnancy does not cause any problem because at the parturition some RBCs will enter and they will have their lifespan. Let us see. Fetal RBCs enter during the parturition. Next, what happens in the mother? Mother has now encountered a foreign antigen, that is D antigen, which normally she does not have. Mother develops antibodies against this foreign and against positive cells. This is a positive cell which is foreign to the mother, which is Rh negative. And our immune system gets sensitized to the foreign protein and slowly develops antibodies. Few antibodies, these are the immunoglobulin are developed. Next, we will come back to this a little later. Next is the next subsequent pregnancy or pregnancies. If at all few RBCs enter during the pregnancy, even one RBC enter, there is Rh positive cells enter the mother. She's already sensitized to the positive cells. One enters also. Anti-D agglutinins or antibodies, IgG type, rapidly develop. And these anti-IgG antibodies cause the placental barrier. Like this, the development, they cross the placental barrier and hemolyze this because these are against the D antigens. So in the fetus, there will be hemolysis. This is what happened in the case. In the subsequent pregnancy, in the previous abortion, some RBCs have entered, sensitized the mother. Mother has already developed antibody. In the third pregnancy, when the child was born, the fetal RBCs were already destroyed by these IgG. The mother has already developed agglutinins and TD agglutinins, and they have destroyed. This is cause of hemolysis, and this will cause erythroblastosis. Now, if you go to the previous slide, NTD, if you administer anti-D in the first pregnancy, what will happen? The purpose is to destroy these positive cells in the mother. Soon after the pregnancy or abortion or delivery, you administer antibodies. So even if few RBCs have entered into the circulation, these positive cells are destroyed, so that there is no question of mother being sensitized to the foreign body, that is foreign cells, foreign antigens. The antigen does not cause any problem. Immunological changes in the mother. This is the purpose. Anti-D antibodies destroy the Rh positive cell. So now if you look at the answer, destroy means the positive cells are attacked by the antibody and there is agglutination. This is how the antigen antibody reaction here is called agglutination. Positive cells are agglutinated and hemolyzed. That is the destruction. Antigen antibody reaction occurs and then cells are damaged. They do not cause agglutination of the Rh negative cells because the anti-D does not affect the negative cells. So B is out of question. Prevent antigen antibody reaction. Antigen antibody reaction occurs The antigen antibody further reactions will not occur in the fetus, but antigen antibody reaction occurs in the mother. So C is not an actual answer, half answer. The better answer is cause agglutination of Rh positive cells. And the D is hemolyze the Rh negative cells. Now agglutination or hemolysis of negative cells is out of question. So this is the pathology of erythroblastosis fetalis.